Good morning, my name is Francesco Maura. I'm from Memorial Sloan Kettering and I'm a myeloma doctor. And in addition to my clinical activity, I'm also working with my lab to understand why myeloma happen, how myeloma evolve, and develop mechanism of resistance to our most innovative therapies. While during this IMS, we listen a lot of innovative science. But in addition to the innovation, I think the feeling is that the field is moving forward fast. Many new drugs. And these drugs are developed with more maturity from the community, more attention to the side effect and how these play a role in our selection, in our decision, and how we should dose and minimize their effect. I think because myeloma patients, or most of them, now achieve a prolonged time of remission, investing time in discussions and studies to understand the quality of life measurement and reducing side effect is, of course, one of the priority. During this conference, my lab is presenting, I think, a groundbreaking work that we perform in collaboration with multiple institutions, including Mayo Clinic, University of Milan, Memorial Sloan Kettering, MD Anderson, NYU, University of Miami, and Moffitt Cancer Center. We collect a very large data set of patients with smoldering myeloma and MGUS with available genomic information. And I think we developed for the first time a model that define the malignant transformation. So in solid tumors, when you have a nodules in the breast or a polyps in your GI tract, you do a biopsy, and if it's a malignant, they call it carcinoma in situ. If it's not malignant, they call it benign. So we don't have this classification in myeloma. We call that smoldering, which is basically we don't know, or MGUS, which basically is less than smoldering. So to get to this type of definition, we leverage genomic comprehensive analysis, and we can define a populations that never progress and a population with a risk of progression. Most important or interesting from the scientific and translational standpoint, the patients with risk of progression show genomic features of transformation that are similar, if not identical, to the one observed in multiple myeloma. So that poses a really important question. Why these tumors are already there, but they don't proliferate and they stay quiet for 8-10 years? Why? What's the mechanism? Because if we know that mechanism, we can leverage the mechanism also to treat patients, to prevent smoldering progression, or to improve the duration of MRD negativity. So we think it's due to the immune control, that somehow our immune system play a key role in keeping these tumors quiet for many years. And understanding this, of course, will, we think, further promote the development of immunotherapy and hopefully cure myeloma. So there are two important points here. So one, the bad news is that it's not available, but the good news is that it should, and there are currently the conditions to have it. The recent International Myeloma Society International Myeloma Working Group guidelines for high risk require DNA sequencing as mandatory to define high risk multiple myeloma. So what we are proposing is the same concept should be applied to smoldering. Now the real question is, if you have a smoldering high risk based on genomics and clinical score, is that patient already a multiple myeloma that should be treated with the 4 drug regimens, or is still a smoldering where we can leverage the immune control to control the disease on a long time? I think these are important questions that require a strong collaboration between clinical trials, pharma, and translational labs like mine, and to really understand who are these patients and what would be the best therapy to prevent organ damage, but also to achieve the longest and durable response.